Just one. Hey, Nikki, John. Did after he got restarted on that Biktarvy and had the little bit of liver enzyme flare, did we get a Hep C viral load since then to see if he still has active viremia?
I believe I have. I can pull it up because I believe that happened a few months ago, and then yeah, so that 14,000 was after that flare.
Okay, bummer. Okay,
His were normal at that point, so I'm not really sure what precipitated that. He was asymptomatic. If we hadn't happened to check his lab work that day, he wasn't having any concerns. It's just something we picked up on his lab work and then has since resolved.
very cool. Yeah, the rationale for me asking, this is for the group. I know you know, Nikki. When antiretrovirals are initiated, you can, as your immune system reboots, you can see what's called IRIS, the immune reconstitution inflammatory syndrome, and that can be basically the immune system recognizing disease processes that it otherwise had sort of let passively ignored. Bad description, but hopefully no domain. And the viral hepatitis can certainly be something that the body irises too. You know, classically it's a mycobacterial disease or cryptococcus or something like that. But the viral hepatitis can induce an iris phenomenon, manifesting anything from mild transaminitis up to and including fulminant liver problems. But anyway, doesn't sound like that was this guy. But for just the sake of discussion, I know Kaylee had looked into this case. I may defer a lot of it to her if she's on still.
I'm on. I had a few questions, Dr. Brian, just because I kind of had some issues with the audio. I was trying to get onto my computer, so I might have missed you saying this, but when he was treated before, was it out of state or was it through our clinic or a different clinic in the area? Do you know any of those details?
It was in state, but not in our clinic.
Okay. Just because one of the things I think of with retreatment is some we can get it approved easier if it was out of state. Would he had a relapse or like kind of fell out of care? Do you know if it was with injection use or what substances he was using? Anything specific from that?
I don't know about sort of any specifics around that.
Gotcha. Okay. And then I saw you'd got an MRCP or somebody had ordered an MRCP on him. What was that for?
Yeah, I mentioned, so he had the ultrasound with the elastography, and the radiologist had commented that he had like an area where they couldn't, on the left lobe, that they couldn't see very well because of bowel gas.
Okay.
And because of that, with the history of Hep C, they had recommended follow-up imaging with the MRI. So it wasn't really symptom-based or anything along those lines. It was just sort of a follow-up request for radiology. So that's what.
Gotcha. Sorry, I think I cut out during that time. I apologize. I mean, does anybody else have any questions first? Because then I can kind of go through what my thought process is, but I'll open the floor first. Anyone? Bueller? Anyone? Bueller? Shut up, John. Not you. Well, so I'll kind of go through and summarize him from my understanding, and then kind of what my thought process would be and how to approach him. So we've got a 35-year-old male with past medical history, HIV, that's well controlled on Biktarvy at this time, history of substance use disorder, natural exposure to Hep B with strong protective immunity, it looks like, who was previously treated for hepatitis C with 12 weeks at Clusa, fall of last year, and then cessated therapy early after about approximately 5 weeks, secondary to some psychosocial issues and some substance use issues. Sound about right, I think. Now, in his case, so kind of overall recommendations are certainly with HIV and Hep C co-infection, we want to prioritize treatment. Main premise is that liver disease can progress faster in these individuals. There's increased mortality, morbidity. His case is a little bit more complex in the fact that, he's already been trialed with treatment and hasn't been successfully adherent. So we're gonna, from an insurance standpoint, gonna have to really justify him getting restarted on treatment again. The positive things I can see are that there's not any concern for advanced liver fibrosis, either through elastography or through fibro test. I didn't see any comments on his MRCP. So from that standpoint, we're at least stable now. We at least have a little bit of time to where if we don't necessarily rush right back into treatment, that we can follow him for a period to ensure that this time around, if he gets treated, he's going to remain engaged in care. How often does he follow with you, Dr. Brian? Like, how often are you seeing him right now?
So I've been seeing him about every 3 months.
Okay. And he's pretty consistent with all of his follow-up?
He's been pretty consistent since he's established care with us.
Okay, gotcha. And where did you say he's from? Like fairly local?
Yeah, he's fairly local.
So I mean, treatment recommendations, and I was trying to log on to the computer so I could actually bring the tables up, but treatment recommendations or retreatment recommendations for somebody that's started therapy but sustained early, that's had more than 28 days of treatment. The way that you approach is you check for SVR. If they still have positive hep C viremia, then we go ahead and follow retreatment guidelines. So he meets that criteria that, yes, he's somebody that we wouldn't restart the prior regimen. We'd go ahead and retreat him and consider this a failed treatment course. The treatment recommendation would be for 12 weeks Vosevi. And so that's kind of considered we don't talk about it too much, but that's considered our salvage regimen. So it's an NS5A, basically drugs from all three classes. So we've got an NS5A inhibitor plus a protease inhibitor plus NS5B inhibitor. It's essentially Epclusa plus a protease inhibitor, voxileprovir. It's a standard 12-week course, but even in patients that have had treatment with Epclusa in the past, there's still a pretty high treatment response with the Vosevi. There's a little bit lower success rate with genotype 3 patients or those that have cirrhosis. He doesn't meet any of either of those criteria. So I'd feel comfortable with 12 weeks of Vosevi once he's demonstrated ongoing commitment to care. There's also an alternative too. Mavorite for 16 weeks would be another treatment option for him. Neither one do I see any drug interactions. Probably the reason why I would go with the Epclusa, it's a shorter treatment course. So I would prefer that if insurance will pay for that treatment. And I wanted to bring up, I don't know if maybe Rachel or somebody else can pull up the HCV guidelines table on HIV and hep C drug.
I have it pulled up. If
you have,
if you want to share my screen, Elizabeth. I don't know if I can do that. Share screen. Oh, never mind.
You should be good. You should be good. I just gave you the capabilities.
Now you're a co-host.
Can you guys see that?
Yeah.
You'll see that. So Biktarvy has an integrase inhibitor and 2 NRTIs, and it's in the green for everything. So it's great.
The only thing I'd want to point out, he's on tenofovir. Well, Biktarvy has tenofovir alafenamide, so we're okay with that. But if he was using like a TDF based regimen, you'd be either wanting to change to a different formulation or monitoring his kidneys more closely. But there's really not any specific monitoring with Vosevi and the HIV regimen he's on. So we're clear from that standpoint, which is pretty good. Nikki, I'll also say, because I think he has Medicaid, there's a retreatment form that you have to go through, that you have to fill out when you submit him. It's similar to an appeal, but there's several questions that you have to answer to kind of justify why he would be ready for retreatment this time. Angie had sent it out a few sessions ago, and I can forward it to everybody again. But Rachel already just pulled it up again. Thank you, Rachel. But I tend to take that form and go in with the patient and go through the actual questions, because it asks things like, why did they stop early? What's going to be different this time? How closely are you going to follow that? I typically follow my retreatment patients weekly for the first month. And that can either be through in-person, phone, nurse check-in, pharmacy check-in. And then I kind of follow probably every week or maybe just monthly through the end and through SVR 12, so that you're really ensuring close follow-up. But yeah, I mean, I would treat him again once you feel comfortable that he would be willing to complete it this time. And I'll leave that to your discretion.
Yeah, I guess when you say follow, you just sort of do a touch base, like with a visit or a telephone call, versus like you don't change your lab monitoring per se, I guess.
No, I don't. I mean, I do certainly. I mean, I check treatment week 4 lab work, especially so you show that they're following up in care, and you can show that there's that trend towards undetectable viremia. But I don't do any closer monitoring. It is, yeah, usually I just do a phone check-in just to make sure that I'm not letting them fall out of care. And then Allied Health, the pharmacy, has been really good about, we kind of offset, like I'll call them 1 week, they'll call them the next week. So we're both checking in pretty regularly. The only other thing I wanted to mention, and this is more for the group, because I know Dr. Brun is this too, but when you're looking at his Hep B testing, does anybody have any comments about if we should be following his Hep B, because he has exposure to Hep B? I know we gone over this a couple of times, but do you guys remember? He's got reactive core, surface antibody is positive, surface antigen's negative. Do we need to do any special follow-up from the Hep B side? Is there a risk of reactivation with his Hep B?
No.
Thanks. No, there's not. And just as a side note, he's on Biktarvy. So even if he was somebody that we would be concerned about reactivation, he's also incidentally getting Hep B prophylaxis with the Biktarvy because it contains tenofovir. So just a side note on that too, but that's just something I want to keep bringing up, and because I know we always get a little bit muddled with the Hep B serology.
Well, thank you guys so much. I really appreciate it.
Hey, Nikki, thank you so much for presenting an HIV case. I don't think we've had one. Genuinely. Yeah. And for the group, Kaylee talked about the rapid fibrosis and stuff like that. The only other thing I want to mention to the group is remember that HIV becomes wrong word. Hep C becomes an STI in the setting of HIV. Wow, that's a lot of 3-letter acronyms. But remember, so Hep C and is not normally sexually transmitted, certainly becomes a majorly sexually transmitted process in this setting. So I guess this guy was IVDU, not MSM. But anyway, that's I probably, like, me, I never tell my HIV patients to use condoms. I'm like, don't worry about it. You're undetectable. You're rocking. But for this scenario, until his Hep C is treated, he can spread that about. So.
Excellent. Thank you so much. We really appreciate that. Send in any cases you have. Thank you very much, Nikki. All right, Robin, are you ready to present your 2 cases? We can start with the 48-year-old female.
Okay, yeah, I'm actually going to present one today, and then Mandy is going to present the other. So Mandy is my right hand on this program, so she normally does all the submissions. So just so you know, I like to give credit where credit is due. So my 48-year-old female that we're talking about today, she's very interesting. When she came to me initially back in June, someone saw her in June, and then I followed up with her in July. But her hemoglobin at that time was like in the 7.6. She had gotten depressed after her mother died, and She had had a history of thyroid storm. She had a total thyroidectomy. She had gotten depressed, stopped all of her thyroid medications. She's got severe thyroid eye disease. And so when and then also she was having some issues with excessive menstrual bleeding. And so her hemoglobin was likely low because of that. And then her, her TSH was terrible at that time. But I quickly got her back on some iron. We referred her to GYN to address menstrual, menstrual problems. And now she's back on thyroid medication. So her last hemoglobin that we've done, she responded very quickly to iron, which was good. I followed that up probably about every, 3 or 4 weeks for just a little while to make sure she wasn't going to need a transfusion. But she responded very quickly to that. So now I think the labs that Mandy submitted for me are actually the most recent labs. So it shows that she's significantly better than she was when I first met her. So her medications, she's on statins, some vitamin D, folic acid. She's on some birth control with iron in it. And I really can't remember if she's already seen GYN or not, but I do know that's underway. She's in a treatment program, so she's on Suboxone. And her vaccinations, she's immune to hepatitis A, and she is getting her hepatitis B vaccinations. So yeah, her last hemoglobin there was 13. Her creatinine 0.17. Let's see, her liver enzymes were good. Her APRI score is 0.196, child Turco-Pugh, class A, and she has a MELD score of 8. So, I think, so she's a genotype 1. I think she's actually due for a follow-up here pretty soon, but I think that she'll be now that we've got her stable, I think that her best treatment is probably going to be Mavorite. And that's all I really have from my standpoint on her.
Thank you so much. Are there any questions for this case before we go into recommendations? All right, go ahead and unmute if you have recommendations for this case. Thank you.
Robin, it's Kaylee. Thanks for presenting her. So looking at her meds, I probably would actually recommend Epclusa for 12 weeks. And that's mainly from she's on that statin, which interacts with the Mavorite, which technically you could hold if you felt comfortable holding it. But also she's on the contraception, which has ethinyl estradiol. So she'd have to hold that or switch to progesterone only to use the Mavorite. There's that risk of it's actually contraindicated with Mavorite because it can cause a pretty significant ALT elevation. So I would prefer 12 weeks Epclusa just so you're not necessarily moving all of her medications around. There still is that potential for that drug-drug interaction with the statin and Epclusa too. But you can probably hold it since you're really just treating her cholesterol, and it's only for 12 weeks. But if you didn't feel comfortable holding it for that duration, just monitor for myalgias and certainly rhabdo, like those kind of things, because that's the concern. You can also do Harvoni for 8, because she meets the right criteria for a shortened course of Harvoni, but I doubt you're going to be able to get that one covered under her insurance because it's not one of the preferred agents. So just so we don't forget about that one, if the viral load's less than 6 million, there's no cirrhosis, there's no HIV, we can actually treat for a shorter course, but yeah, not probably not going to be covered. And then her partner should be tested. I don't know if that's still her partner, but the one that had Hep C that you mentioned, if they're still together, he should really be tested and or not tested, treated. And I would probably just still get a pregnancy test on her prior to starting treatment. I know she's on birth control, but just with any female of childbearing age, unless she's postmenopausal, I'd probably, still get her, still snag a pregnancy screen. But John, you want to talk about the thyroid?
No, you just did. No, okay, yeah, happy to. The this lady's liver is not going to be like your primary motivation to treat her. This is one of those classic examples where she's had it and doesn't have any liver damage, so that's great news. But motivation to treat simply because that immune activation may or may not have some relation to her autoimmune disease at baseline, and that's kind of the punchline. If you do have any sort of autoimmune disease with Hep C in the background milieu, you'd love to shut down that pro-inflammatory stimulus. It may or may not benefit her thyroid and exophthalmos, et cetera, but man, it'd be great if it does. So extra motivation to get rid of a curative chronic viral systemic process. And the thyroid is really kind of renowned as being one of the autoimmune target tissues with Hep C. So always a good idea to remember to TSH on your screening, TSH on your evaluation with your Hep C intakes and so on and so forth. But good job.
Thank
Okay.
you so much.
I just had, this is not related to this case, but I've been meaning to ask this. This is completely a separate patient, but I just had a quick question, if that's all right. I have a patient, I'm just curious about this to know if this is common. I had a patient way back a long time ago when I was a labor and delivery nurse who was Hep C positive. And I know for a fact this one stands out to me because she used to be, long before she went down some bad decisions. She was a friend of mine. So I helped her deliver her babies, at which time she was Hep C positive with an active viral load. So of course, years later, now that I'm in this position, she actually came here through a rehab program, and I rechecked her Hep C as part of this process, and her Hep C antibodies were even gone. And so I know for a fact, I remember her, being positive for Hep C, but now there is zero trace of Hep C antibodies. And of course, does that happen often? Do you all see that the Hep C antibodies will often just completely go away?
It does not often, but it can. It can, but we don't tend to see it occasionally. I mean, is she on any kind of immunosuppression or have any immunosuppressive conditions, because sometimes that can preempt a negative antibody. But yeah, we don't commonly, we always say, just let patients know to expect that their Hep C antibody is going to remain positive lifelong, even if they don't have active viremia. But in rare instances, it can turn negative. Why or who that happens with, I don't see it enough to have any for that. I would say, just kind of interesting about the fact that you helped her deliver, is that remember, with each pregnancy, there's about a 10% chance of spontaneous clearance of Hep C too. Oh. We don't want to tell our patients get pregnant, so maybe you'll clear your Hep C, but there's about a 6% risk of vertical transmission. But that's something that's kind of quirky that we can see occasionally too. But yeah, that's really interesting, because I don't see that, but it has been described, just not something you'd expect.
To make sure I wasn't lying to people, because I told them always to make sure your Hep C, your Hep C antibodies they're going to be there, and then that one just kind of threw me for a loop. So I've been meaning to ask about that. So I appreciate your input.
I still counsel them that we expect that it's going to stay positive. But yeah, in her case, she's lucky. If she's not immunosuppressed, if that's the case, and she's truly cleared, like there's no active viremia, she's not immunosuppressed to where that may make that negative, then I mean, technically we tell people you can't donate blood. she I guess if she could, if she wanted to, because she doesn't have those antibodies anymore.
Okay. All right. Thanks, Haley.
Great. Thank you so much. All right, Amanda, are you ready for that next case? You're still on mute, Amanda.
Hey, sorry, I was on the phone and just had my camera off and didn't even hear you guys say hello. So,
That's all right.
yeah, stuck, sorry. Okay, this is a case of a 62-year-old female. She came to us to establish care of the PCP. So she wasn't like our typical people that we get screened from. But she did have a history of the substance abuse with the IV drug use. And according to her, she was diagnosed over 20 years ago, has never received any treatment. She's been sober and in some form of treatment support for at least the last 11 years. Right now, she's currently doing a methadone program. And she seems to be stable and doing very well with that. So she's not using any alcohol, and she's still smoking, even though she doesn't need to. But I guess can't quit it all. So she's doing better than what she had been. But with her waiting so long and her comorbidities that she had some abnormal liver ultrasounds come up. I sent that as an attachment in case one of the higher up people wanted to look at it too, like John, so he could review it. But I know with some of her other comorbidities and the medications we use to treat, that was why I wanted to have you guys look over and review the case. Her medicines are fairly the same as just about all of them. She's anemic and, low potassium. She's got some breathing issues, so the inhalers are on there. She does have high blood pressure, and she's taken acid reflux medicine. I know that there's been indications with those meds that you couldn't take some of those with the treatments that we use. She did do her vaccine series that she had. The Hep B that she's immune to, from what I can tell, came from exposure. She did have Hep A and the other stuff that was required. Her white blood cell count was good, and H and H2 platelets were normal, not having any kidney issues at this time. Really, her liver enzymes were okay. But when we did when I did my calculation stuff, her APRI score was 0.345, and she had a MELD score of 7. The CTP was 6, and she's still in a class A with that. Iron, TIBC, her vitamin D is stable right now without treatment. I didn't know if we needed to start that where she's already above 60, and that's where you guys have been saying that they wanted her to be. But her fiber score came back high when we did labs at 0.26. I was reading my notes to make sure I didn't miss anything. She's had a tube ligation, so we weren't really concerned with the contraceptive thing, and she's 62. Let's hope not. Anyway, but my question was that her fibro stages were F0 and F1. But with that liver ultrasound being abnormal, we had ordered an abdominal CT, and it's scheduled for the 19th of this month, and it's approved. So hopefully that'll help some. But her hip cord B, when we drew it in January, came back indeterminate abnormal, and the AB total was positive. So I didn't know with that. She's coming in tomorrow, so I had put on there to maybe redraw it to see if it had, I don't know, changed any since the last time we did her labs, but I didn't know with that if she needed a 12-week course, or if she could do Maverick at 8. So I just wanted you guys to look at it. Y'all are the go-to people.
Thank you so much. Does anybody have any questions?
Andy, do you have a surface antigen or a surface antibody by chance too for Hep B?
Yeah, she was, when you did the surface antibody. No, see, that's why I don't understand. Like when we saw her and do a normal set of labs, we do the surface antibody like the SBAG or whatever. And for some reason, somehow it didn't make it. So I'm pulling that tomorrow, and then they do an HIV screen on her too, because I guess she wasn't a typical like adult exam. So when we started, she had other issues coming in, and she was sick and couldn't breathe. And, I think that we kind of stumbled onto the Hep C and all that extra stuff with that. So she's a regular patient, and she does keep her appointments. So we're just trying to get her taken care of. And I knew that one of those things needed to be treatment. So now I'm going to do more blood work again tomorrow and hopefully have some extra stuff.
Thanks for clarifying, Mandy. For some reason, I know you said that you attached the liver ultrasound, but I don't have it to look at.
You didn't come through?
I don't know if maybe
I didn't get that attachment either.
Okay.
If you have the report and don't mind reading it, then we can try to at least start there.
That might be a boss thing. No, I'll go get it. That might be a call wrong back thing. It said that they compared it to an abdominal CT in 2013, which she didn't disclose to us that she had done. So I don't have that report. I'm trying to get it, but I just don't have it to look at. So she hadn't obviously had anything done though since then, from what I can tell. But it said that several sections of the right abdomen available, non-uniform echo pattern of the liver without distinct focal mass. Hepatic duct is abnormal and dilated up to 12 millimeters. Intrahepatic bile duct dilation was observed. The patient had a gallbladder removal. The vena cava appears somewhat distended, including the hepatic veins. Question trace of ascites surrounding the liver anteriorly. And then it says the patient wasn't tender in the upper abdomen during the examination. But when you go on down, it said that non-uniform echo pattern of the liver could be due to fatty infiltration with no focal masses. Hepatic ducts dilated to the 12 millimeters. Intrahepatic bile duct dilation is also seen, and they recommended the follow-up abdominal CT with contrast, which we've got scheduled. So it says somewhat distended appearance of the IVC and hepatic vein, trace of ascites on the interior of the liver, and visualized right kidney sections appear unremarkable, with no hydronephresis.
Yeah, I'm not particularly worried about her having cirrhosis of the liver, advanced fibrosis, because it probably is just fatty infiltrates. There's not any masses. I agree. I would do the CT first, but I bet the ascites is probably just from her CHF and her other kind of comorbids.
And that's what I was kind of wondering too, like with her age and everything else she's got going on, if some.
Yeah, and then those that dilated
stuff showing up on these scans wasn't just because of years of neglect.
Yeah, and sometimes, yeah, right. And so, and then even, you said it was her common bile duct that was dilated up to 12 millimeters, but she's not symptomatic, and I think liver enzymes were okay. That can sometimes increase with age too, or even with certain medications can cause that to increase, like the methadone. I would just see what the CT says, if that still shows there's some swelling of that duct, maybe even get an MRCP. But I don't necessarily think that that should preempt Hep C treatment if that's something that she's ready to pursue, because I think we have enough other objective data that she doesn't have liver cirrhosis that you could go ahead and safely treat her. Is that what John, do you agree, or what are your thoughts?
Yeah, no, my read on the bile duct is probably post cholecystectomy. I agree with you. It's a little bit big, but up to 1 or 10 millimeters. Yeah, 100% agree. I was going to punt over to Rachel and specialty pharmacy to see if there was anything with regard to drug interactions. The one thing I wanted to bring up, because we rarely talk about it, it's unrelated, but the IgM that you saw in the core, and I 100% agree with Kaylee, by the way, you need your hepatitis B surface antibody and surface antigen to clarify what's going on. She certainly had core antibody positivity, which means prior Hep B exposure. And we need to know if she's immune. So the surface antibody would be key. But the IgM.
Oh, she is immune. I'm sorry. Yeah, she's immune, John. It showed up that she's immune to Hep B. Yes.
Oh, sweet. Okay, cool.
Yeah.
So we're rocking that then. Nothing to worry about. And remember, don't let a lab convince you that a person has an acute Hep B. So, and what I mean by that is we all learned that IgM means acute and IgG means more chronic. The reality is people can maintain their IgM positivity forever. And that especially is true for Hep A but true for the IgM core as well. So if you look at graphs of the IgM core, it always looks like it disappears after a certain amount of time and then gets replaced exclusively by the IgG core. That's not true. Like Kaylee and I both see that all the time, where people have persistent IgM core. And so really what you'd need to call someone an acute hepatitis B or a recent Hep B is absence of the IgG, number one, some clinical syndrome that fits, and a recent risk factor. And so I'm not at all worried about you redrawing the core. I wouldn't even bother. As long as you've got your surface antibody present and you know that the core had been positive, you can just say previously exposed and immune. And yeah, I agree 100% with Kaylee too. I'm not stressing on the ultrasound, at least from the perspective of hepatic fibrosis. What a weird disease Hep C is. She's one of these natural history ladies who she fits into that 20 years plus of infection and still F0. So crazy, too bad not everybody goes that route. Still want to treat her, obviously. And then
and with her genotype being 2B, I know you told me before that's kind of aggressive for her not being part of the
believe it or not, that one's not. So yeah, genotype 2, we're okay relative to 3. It's 3 that's the nasty one. It's 2. I don't know anything special about 2 really. It's other than you can't use some of the drugs. It used to be an easy one to treat, still is sort of. So you should do fine. I think she's going to be in good hands with you. Just remember that you're stuck with the pan-genotypics, so the Mavorite or Epclusa. And then Rachel, I didn't run the drugs or anything, and my brain maxed out at like 2 drugs, so I can't do it in my head.
I think Mandy, you already had mentioned as you were running through this the problem with the Nexium. So PPIs and Epclusa are always going to be an issue. Epclusa and Harvoni always having those acid suppressing things. So with Epclusa, technically, you do have to use the either one, they recommend not using any PPIs if you can avoid it. So potential to hold it, change to one of the H2 receptor antagonists like Pepcid or famotidine. But if they have to use the PPI, change it to omeprazole, and 20 milligrams is the max. And Epclusa has that weird thing where we have to kind of schedule it with the patient. So it's taking the Epclusa with food, and then 4 hours later, they take their omeprazole 20 milligrams. So you have to kind of set that schedule and set that up with the patient if that's doable for them. That's the only major interaction that I see overall. No real major concerning thing with what you've got listed here in the Mavorite, assuming there's no sort of ethinylestradiol for like hormone replacement or anything like that, which you don't have listed here. So yeah, that's all I see.
Great. Thank you so much, Amanda. And thank you everyone for your input. Really appreciate it. All right, we have one more case, and that's going to be with Jennifer. So I'll go ahead and share my screen.
Thank you. Sorry I was late. I wish I had heard that first case. I'm going to go back and listen to the recording. all the cases were interesting in that one in particular. I'm sure I could learn a lot. So I think this will be pretty quick. This is a 27-year-old Caucasian male with Medicaid insurance who I saw several weeks ago now. He was diagnosed, or he first found out about his diagnosis in 2021 when he was in treatment for substance use disorder. He's never had treatment, and he was sent to me by one of my colleagues. He is 27 and has been using had been using intravenous drugs since age 18. He's been sober for 5 months now on Sublocade, doesn't drink, doesn't have any other risk factors. At the time I saw him, he wasn't sure about his Hep A or B status. It turns out he has immunity to Hep B from vaccination, and we've started him on Hep A vaccines. He didn't have any, he had a negative review of systems when I saw him. He was a nice guy. He's looking for work. He has anxiety disorder, and the medications that he's on are to treat that. So Lexapro, hydroxyzine, propranolol, and trazodone. And then you can also see the Sublocade there. That's his story. He had a BMI of 25. His CBC was normal, renal function normal, ANR 1.1. He did have some transaminitis, as you can see there. ALT and AST were elevated. His APRI was 3.02, child Turco-Pugh class A, MELD score 8. He his iron studies were normal. Vitamin D was great. He's not on vitamin D. I never see that. He's HIV negative, genotype 3, viral load of 1.6 million, and his serum fibrosis marker put him at an F0. I was thinking either Mavorite or Epclusa. I didn't check drug interactions, but I didn't think there was anything there that was a problem. And then I just looked. I don't think we actually ordered ultrasound or elastography. I thought we had. Actually, I thought the referring provider had ordered it. So I can still order that, but my other plan was to repeat his APRI after treatment, and I probably expect to see it come down. So I guess, should I still proceed with elastography or ultrasound is another question. That's my case.
Thank you so much, Jen. Does anybody have any questions before going into recommendations?
Hey, Jen, what about alcohol use? Do you know anything about his alcohol intake?
He denied alcohol intake. He denied drinking. I don't think I asked about prior to when he was using IV drugs, but he is not drinking now. I could look for a GGT if you would want it. Okay.
If you happen to have one. If not, I don't know if it would really change management, but if it's high, it could be helpful, sure. And then his fibrosis marker was F0. Was there a lot of necroinflammation though? Was it like A3?
Let me pull that up. His necroinflammatory score was 0.98, yeah, A3. And his GGT was 79. Let's see.
Is that elevated? I don't even know.
Upper limit of normal is 65 on that.
Okay, gotcha. Yeah, I may clarify with him the alcohol.
Okay.
Just to be sure. If no one else has questions, I can go into recommendations.
I think you're good to go. Thank you, Kaylee.
Yeah, I think in terms of drug interactions with his medications, I don't see any that would to where I'd prefer Maverick over Epclusa or vice versa. What I would suggest though, so he's genotype 3. He's got an elevated APRI, which you're correct. It could be falsely elevated because of his degree of transaminitis. You have an F0 on his fibro test, but I would certainly order liver imaging mainly because of the transaminitis, but also as an alternate modality of his fibrosis. He's 27, so you wouldn't think that he'd have any significant fibrosis. But remember, with genotype 3, if you do have a patient with cirrhosis, in order to treat with Epclusa, you'd actually want to do that baseline polymorphism testing. So in his case, I would say, I would probably err on the side of I'd go with Maverick for 8 weeks. Just so if you're going to plan to treat him before those ultrasound results are back. So my approach with imaging, is I tend to like elastography a little bit better than the fibro test, because then you get a visual of the liver contour as well, plus a fibrosis assessment. But if you feel really confident that we're there without fibrosis, then you can possibly get away with one over the other. But with transaminitis, I always like to make sure we do imaging as well. It doesn't always have to preclude treatment, but in his case, just because he's genotype 3 and his APRI is elevated, then I probably would get it first, just to make sure there's no concern for advanced scar tissue there. I checked a FIB4 on him as well. That's another calculation you can do with just your hepatic panel and CBC. It didn't really give any information. It didn't really rule out or rule in concern for fibrosis. It was kind of like right in that middle where it's not really giving us anything useful. So for him, I would probably say go ahead and do Maverick for 8 weeks. In his case, if that's the case, you can just order imaging and don't have to have the results back before you treat. But if you are going to use Epclusa, I would make sure you have the elastography back. I thought I was going to say something else, but probably not. So somebody else topic.
I'll just say quickly, that was really helpful, Haley, and for this guy, and also just for reminders. And yeah, I must be catching, because I was going to say something else too, and then I forgot. I'll double check with him on the alcohol use.
And just a thing for him to consider, if he is like using any sort of alcohol amount at all whatsoever, he's on a lot of medication for anxiety, like really heavy doses of a lot. And that's not going to be helpful to him. So just a point out for him to kind of consider.
Yeah, nice. Thanks.
Yeah, thanks so much for that. That's why we need BMed in these sessions, because you guys can give those good points that we may not think of or overlook.
Listen, I saw that and I was like, what on earth I was like, this dude must have anxiety up the wazoo if he's, on all of that all the time. Because poor thing, it's a lot.
Yeah, when I look at it, I'm just like, oh, he's on meds. And then I just glaze over. So thank you for bringing that point up. I remember what I was going to say, Jen, because your question was, should you repeat his APRI after treatment? Yeah, I totally agree with you. I think that you should, especially if it's that outlier. Yeah.
Thanks.
I agree. That's a good question.
I wish I could remember what the other thing I was going to ask, but it's long gone. So thanks. Yeah, I thought that was an interesting combination of medications for anxiety, especially like that, the high dose of trazodone and also the propranolol in there. Kudos to whoever did that instead of some.
And I guess if he's taking the propranolol and the hydroxyzine like as needed, it would be a little bit less of a concern. But if he's taking them like regularly, especially, it's just something to be pretty aware of for him, especially just going down the line, because the alcohol is not going to help. Even like a 1 or 2 glasses of wine type thing, I'm not talking like overuse, but it's just not going to help him at all in the realm of treating his anxiety. So just something for him to know.
Nice, thank you. Yeah, I can't remember what else I was gonna ask. I feel so sad about that.
No worries. You can always bring it up next time. Thank you so much, Jennifer, and thank you,
welcome.
everyone.
you all.
Yeah, it's been a great session. Thank you so much for all the cases. We had one that couldn't make it, so we'll just postpone that one, but it actually worked out perfectly because we're right at the time. So I just have one announcement. Next time we're going to meet will be, I think, September 28th with Rachel Mitchell and Marissa Barton. They're going to be discussing adherence. So I hope you guys have a great rest of your week, and I will see you soon. Bye-bye.